אוקיי, אז ברוכים הבאים לכולם. And welcome to גרסיאלה. אני אגיד ממש כמה מילים קצרות מאוד בעברית, לפני שניתן לגרסיאלה את מלוא הזמן שלה. אז קודם כל, ברוכים הבאים לערב קהילה מקוון בנושא טיפול אקט לכאב וטראומה, שכידוע התקיים באנגלית על ידי דוקטור גרסיאלה רובנר, שמיד תציג את עצמה. שתי הודעות קצרות. הראשונה להזכיר שמי שמעוניין, ככה כמו בערבי הקהילה הלא מקוונים שלנו, שהזמנו אתכם ככה לתרום למען הערב והמרצה שהשקיע ממרצו להכנת ההרצאה, בגלל שגרסיאלה לא נמצאת כאן, אז יהיה לינק בצ'אט לפייפל שלה, ואתם מוזמנים לתרום כמה שאתם מרגישים שנכון עבורכם, לטובת המחקר שלה והמשך העבודה שלה על אקט וכאב וטראומה במרכז שלה. אני גם מזכירה ממש בקטנה שעד יום שישי הקרוב אפשר להגיש מועמדות לרשות הסניף הישראלי של ACBS. הבחירות התקיימו ב1 לספטמבר, ומי שמעוניין להשפיע ולהצביע צריך להירשם ל-ACBS ושם לסניף הישראלי, וליאור תכף ישים לינק גם לזה בצ'אט. אז יהיו שם שני לינקים חשובים, ועכשיו נעביר את רשות הדיבור לדוקטור גרסיאלה רובנר. Graciela, thanks for being here, and I'm giving you now the stage.
Thank you for having me here and inviting me. It's a real honor. I was supposed to be there for some couple of weeks ago, actually. So I'm very happy that we could do this by Zoom. So welcome to everyone. My name is Grasiela Rubner. I'm in this very moment sitting at my friends in Stockholm, Sweden. Otherwise, I live in the second city in Sweden, which is Gothenburg, and that will be the west in front of Denmark. And here is my colleague also. I teaching in Karolinska Institutet, which is a medical school. And I think I'm going to start sharing my screen. Let's see here. And let's see. Yeah, here we go. Let's see if this works. Here we go. It's a bit slowly. Here we go. So I'm going to talk a little about chronic pain and trauma, my specialty. I've been trained as a psychologist in Argentina, but when I came to Sweden, I decided I didn't want to work. I was a body-based psychologist already in Argentina. And when I came to Sweden, I wanted to keep on working with the body because even if I learned the language very quickly, I felt that there were some non-said verbal cues in this culture that was that made me decide that I wanted to work more with the body. So I turned to be a physiotherapist. So I studied as a physiotherapist. So from being a body-based psychologist, I became to be a behavioral-based physiotherapist. And my specialty as physiotherapist in Sweden is chronic pain and mental health, which is quite big in Sweden, mental health and chronic pain specialty. Then I have also another psychology master's and a medical master's, and my PhD is in medicine. So I've been working for many years with ACT but my focus has been to try to somehow translate or adapt the ACT processes, what's behind ACT, which is a psychotherapy, but what's behind ACT, in order to be able to be used by other professionals as well, and for the interprofessional team, which is my specialty. I've been working mostly as a clinician in interprofessional rehabilitation, pain mainly, but it will be pain and mental health normally. So what else? My idea today is to present a little of the work I've done, and also try to think about how pain and trauma, what do they have in common? Now, you have been seeing, I hope, these small videos. So there is some information in there, and you are going to discuss together a little about this. And then we are going to touch upon what I meant that is behind ACT, this mechanism of change or the processes that ACT build on. And after that, we are going to do some practice. These are, it's called the triaflex, and behind you can see the hexaflex. You that know about ACT. I use pretty much these three: open, aware, and active, with the medical community and also with psychologists. And then we are going to talk about what's changeability. And then I'm going to present the profiles of behavioral flexibility. I call it behavioral plasticity based on our research in my lab. I'm supervise master students in physiotherapy and also final medical students. They do research with me. So we have been doing things together. And then we are going to try to cook this together to understand how this research can help us, this research understanding different profiles or different behavioral patterns in behavioral plasticity, what in ACT is called psychological flexibility. Different patterns of psychological flexibility will inform us clinicians in how to design our interventions, which process we need to prioritize or start with, or why. So the first thing I would like you to do is to start thinking about what you think pain and trauma has in common. And so I'm going to put you in break rooms. I think I can do that, yes, while sharing. Because one of the ideas of this meeting for me was also to contribute in you guys having a good networking and exchanging knowledge, because I think that's very important. I work a lot with peer support groups. And this is, there is a model we use that's a little tweaked, a little different than the normal ACT model that I use, that helping each other with ACT, but also helping each other with own behavioral changes. So I would like you to talk with each other and then write in the chat. So let's see if I can do breakout rooms. I'm going to do, let's see here. And if some of you are alone in a room, just wait, because I can put someone else that was kicked out. So don't come back. I'm going to fix that. So you are going to be 2 or 3. Let's see. Yeah, I can do 100. I can do less. 2 or 3. Here we go. And so you discuss this, what you think they have in common, and then you can start writing in the chat. Okay. So here we go. You go to so welcome back. Now you can start writing in the chat your ideas about what are the shared things between chronic pain and trauma, you think?
Do you want it in English?
Yes, yes, please. English, Spanish, French, Swedish, Portuguese, Italian, not Hebrew. I'm sorry for that. There are similar neurological mechanisms in response to pain and trauma stimulus and behavioral response in attempting to control or avoid the experience. Exactly. That's exactly the answer I was looking for. There are both things that feel permanent, yeah, and painful. Mm-hmm. Trauma, unfinished and resolved mental pain, mental distress, physical stress, mental stress related to each other. Both the human suffering, chronic pain often sits on a basis of trauma. They are related, that's true. We wish to avoid them both, I think, not only it. This was in Spanish, trauma and pain are putting us out of balance. It's experience we try to avoid, certainly so. Both pain and trauma may lead to avoidance and interfere with valued living. Trauma can cause pain, and pain can cause trauma, exactly so. Something people try to avoid, yet we will try to teach them to live with that. So then in both cases, the patient speaks about before and after. Yeah, before the trauma, before the pain, how life was there, certainly so. Repressed emotions in the body can happen, of course. No control or feelings. Attacked by both pain symptoms. I don't know why this is moving that much. So, hypervigilance, that's one of the responses, absolutely. Pain is experienced differently depending on negative emotions because of unresolved trauma. That could be one, yeah, way. Both are remembered in the body's memory. Pain causes trauma and vice versa. Trauma is pain that is not released. Both are unpleasant experiences. It is culture related. That's interesting. That's interesting. It is, really. Both have an anxiety properties, both immobilize. Yeah, that's one of the responses as well, to get paralyzed. Pain can be a way of avoiding dealing with trauma that create dissonance. Both are very intense experiences. Yes, both can lead to lots of values, to loss of values in life. In pain and trauma, the secondary suffering can be more difficult than the experience itself. Yes, the consequences, exactly so. So you are really nailing this. You are one and another really writing. I'm going to read the last, a feeling of betrayal of the body. Yeah, there are a lot of people explaining that. And both lead to anxiety, could, and unpleasant and unwanted experience, not always predictable, not. That takes you out of balance and transforms your thoughts and feelings. Sometimes there are clues, and sometimes it's experienced as an unpredictable and invasive, exactly. So all of you have nailed this idea of, actually, what I say to my patients is that pain can be physical, and when they come to us, they come with the physical pain. They think that well, here's my body, I'm in pain. And then they get sort of insulted if we see that we say that, okay, we have a psychologist here, and they say, well, no, I mean, my pain is in the body. But so I asked them, we have pain in the body, we have pain, psychological pain, we can have social pain, cultural pain, but we can have, let's say, physical, mental, and social, which is worst. And then they start thinking, and they realize that, okay, the social pain may be the worst, and there is always mental pain together with physical pain. So it's a way of normalizing this also for the patient. So in the very, very beginning, I make that statement. And as you are writing here, you're pointing to both behaviors that can be consequences of these two pains. And one of the biggest behaviors they're trying to avoid, which is totally normal. And we should do that. We should really avoid pain. And as we know in ACT, as you can avoid whatever you want to avoid as soon as it works. And if you try to avoid and keep on trying to avoiding and it doesn't work, well, that's the point where we need to rethink and find new strategies, right? So that's totally correct. You are on that path. So we are not going to go deep into that because some of you talked about the neurological process. That's a course that I offer, how the neurology and the inflammation influence our behaviors, and how can we change inflammation and neurophysiology with our behaviors. Remember everyone to mute yourself. There are some unmuted. So great, we go to the next one. Here we have some of the strategies. Probably I will say trauma you cannot amputate, but you can drink and try to just escape it, or do drugs, or deny, or control in several ways, with medicine or with like, well, I'm not going to go for a run because, or to a gym because this is going to be painful. These ways of controlling, escaping, tolerating, giving up. You can see all this behavior not only in our patients, they are behaviors that we also use when things are difficult. And so what we really try to do is how can we create space? How can we open to this discomfort and still keep on living a value life? It sounds easy, but you know, it's not. It's not for us, ourselves. It's not easy either to help others. So this model I developed was how to help us to be more effective in this process. So now I have the next question to you. I would like you to put in the chat. That's only 1 or 2 or 3 words. And I do this with the patients also. I always invite my patients. The first thing I do is invite them to a group lecture like this. So I don't meet them individually. I have group information meetings before where I present all these ideas. And a lot of this material I'm sharing with you is actually, for instance, these slides are slides I use with my patients. Because since I'm going to tell them that I'm not going to take out their symptoms, but I'm going to help them to increase their function, physical function, mental function, social function, despite their pain, which is this, right? Creating the space to having this discomfort and still be able to live. So I think that it's empowering and patient-centered to have first an information that I'm not going to do what you actually came for. Well, some people are ready for accepting, but not many. So they can choose then if they really want to keep on coming to us or not. So in that first introduction, I also need to come to the point where they realize and agree that what we are going to do actually is to change some behaviors. For some patients, that's a real somersault. It's like, what? But for other patients, is, oh, that's interesting. Or other patients, is, yes, I've been hoping for this. So it's different. And we are going to understand also why they react differently. So anyway, let's say that we agree. I have other kind of explanations for them to agree that we are going to change behavior. So now my question to you, and I would like you to write in the chat, what do we need to, or what is needed in order to make a change? What's the first thing you need to do or have in order to make a change, a behavioral change? It's silent indeed. Willingness, awareness, yes. Willingness, awareness, motivation, hope, faith, awareness again, willing to change, acceptance, motivation, curiosity, absolutely, insight, yes, 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 stop, yes, you nailed it again. Actually, a lot of us think that we need to be good and motivate others, and the person need to be motivated. No, it's the insight, it's the awareness. So I'm going to give you this slide. Because if you don't have awareness, let's say you have a friend that has this box with wine and he or she drinks a little too much, you think. And if you just try to point that out and say, you know, this drinking, and then the other says, oh, well, it's just a little glass someday, that's not an issue. Then you know that the discussion is finished. You need to have awareness that a change needs to happen. So that's true. So we are going to start here with the very first thing is, as you said, is the insight. So I need to realize, okay, in the surface level is, okay, something needs to happen here, something needs to change here. A little deeper level is, oh, it looks like it's me, the one that needs to do the change, not the psychologist will fix me, or the physio will fix me, or the doctor will fix me, or my husband will fix me. So it's me. That's a deeper. And then we also need to start having a kind of awareness about how do I behave, and when I behave like this and like that. That is a more metacognitive capacity that's possible to train, of course, but not everyone has at hand. So that's true. That's the first step. The second one, there we go with motivation. And there is the willingness, and there is a reason, and there is a meaning. Why? Why should we do this? I mean, making changes is pain in the ass. This is not fun. We know that. It's difficult. So you really need to have a strong reason. And that's, we know, in ACT, we work with values. And why are we going to do this? And then, of course, to have knowledge how to take those steps. And that's where our competencies as professionals come into place. If we are creative and skillful in giving good tools, and tools could be from knowledge to exercises to, you know, all these toolbox we can have in the different professional fields we work. So these two are very important. But actually, if we look around, a lot of our therapies has or offer these two steps. I mean, go to motivational and interviewing, expert in these two. First, increasing awareness, and then working on motivation, demotivation. And so this is something that we also do when we make a change. I bet you at this very moment, most of you or all of you are into at least one project of change. It could be drinking more water or less coffee or more fruit, or go lose some weight or move more or something like this, right? And so this, let's say, insight, okay, I need to lose weight, which I've been doing back and forth in my life all the time. So I always start on Monday. I guess in Israel starts on Sunday. So prepare all this food I bring to my job, to the clinic, and everything for every day. And the first day goes quite okay. And the second day of the week, well, that's okay. And the third, it's just like, but I know normally the Saturday for us is the candy day, that I know that day I will or eat candy or chocolate or pizza or whatever I want to eat. So I'm just waiting for that day. But on Thursday, something happened at the job. The boss come in, he's irritated, I get stressed, and there we go, the chocolate goes in. So I had insight, I was motivated, I start moving, I had action, and then everything crashes. And then we have, in Sweden, another Monday, you have another Sunday, and we start all over again. Have you been there, like going like this? So how is that step called in active rehab? I call it like this. This is the name of the next step. So there is what I found ACT so excellent, so special, so amazing, is what do we do when shit happens? How can we handle it? How can I prepare myself and my patients for shit happens? And that's a very, very secret. So here is to really model and increase compassion, in love, self-compassion, self-love, empathy, self-care for myself, and then self-care for others, and having new strategies to handle these setbacks, these difficulties, and also the capacity, the resilience to be able to have this comfort, like how you say, elite sportsman, you know, or a professional dancer. How do we get there? How can I train that? So this is the model that I use, and here you see again the 3 flags. These 3, I call them ingredients. They're components of what in ACT is called, well, in ACT we use the 6, not the 3, 2 per pillar. And in ACT is called psychological flexibility, but I actually call it behavioral plasticity, in order to understand that it's not only psychological flexibility, it's flexibility body, mind, and socially. So the idea also in this work I've been doing these last 15 years with ACT is that even if all of us, let's say that, if I can start this here, that we see that these are processes, let's see, I can start again. You see these as processes, the 3 pillars, but a profession can work in this way with this tool. Another profession will work with these tools to make this move, these changes happen. Another profession will work in this way. And then the beauty of the togetherness of a team, if you have the chance to work in team, is fantastic, because you can really create this synergy. But the idea is, again, ACT may be a triangle, but the processes are moving, these dots are moving, and the physiotherapist may work with squares and the occupational therapist will work with the star. So the idea is to understand these dots moving, the processes behind ACT, as again, ACT is a psychotherapy, but we can still go back to the dots and understand how can I, from my profession, they are social workers, they are occupational therapists, they are sports trainers, teachers. All of us can then look at our own toolbox and start understanding. In the trainings I offer, is that how we work? So I don't teach ACT in a way that is taught for psychologists only, because, well, there are many trainers that do that. I want to offer this different approach that applies for everyone, respecting our own field and knowledge. What I've been seeing, unfortunately, is a lot of social workers or that are not psychotherapists, physiotherapists, occupational therapists, doctors start being like quasi-psychologists, and that's not the idea. So, how do we understand and embody these processes? How can we work with them? I wanted you to have a feeling of also embody the processes. And now why we should embody, not because you are going to be a physiotherapist, is because when working with people with trauma, sometimes words are tricky. Sometimes words are the ones that keeps us what we call in ACT fusion. It's like stuck in our mind, or there is a lot of lack of words. This alexithymia, not finding words, is also a problem. So what we found in our work is that with people with trauma, especially with very early trauma, it's quite important to start working with the body, especially, you know, all of us have reached to that point where we are doing quite well in therapy, and then you get stuck and you get stuck and you just stuck. And that's where we really need to change language. And that's really where the embody ACT will help. So we are going just to taste this. This is the teaching I'm doing at the medical school. It's called Active Rehab. The last term, it was for physios and occupational therapists. So how to embody the processes. So the exercise, let's see what you are seeing. Here we are. You are going to work after I guide. No, first you are going to write this one thing for yourself. So you need paper and pen, and you're not going to share that. And then you are going to go to breakup rooms after I guide an exercise. So the first task here is just paper and pen, and you just arrive to your values here and now. Why are you here? We are 118 now, so there is a reason why you are here. So, or why? What brought you to choose your profession? So write that, your values, what's important for you. And try to even grasp something. How do you do that? How do you enact your values? What do you do? Which kind of behaviors? So you're going to have now just a short minute or so. I'm going to bring battery for this one. Let's see here. So write by yourself. Great. While you're writing this, also notice how your mind is working to figure out this. Where come the answer from? Mm-hmm. Good. So now I'm going to close this before it rings, but here we go. And so for this exercise, all the exercise I guide are free chosen. That means that you can follow or you can just not follow. If you do not follow, just close your eyes. So nobody feels that is looked by anyone. So we feel free. And so find a sitting position where you have your back free as well. That's just because of the breathing mechanics. The chest also needs to expand backwards. So if you have support in your back, you limit that movement actually. And what else? Nothing else. And then you can decide, yes, also without looking at your feet, just allow your feet and the soles of your feet be on the floor under your knee. So the ankle is under your knees in the distance of your pelvis, sort of. And so I'm just going to also try to have a timer here. And then let's see if you can feel your seat bones where you sit. I have quite a stool actually. So if you take out all your muscles under the seat bones, you may feel them better. And give yourself time just to arrive. To arrive to your feet on the floor, your seat bones on the chair The seat bones are like your feet when you are sitting. And notice this pressure between the seat bones and whatever you are sitting on. That is the gravity working on you. It's a force, like an arrow, bringing you downwards. So each time you exhale, you allow as much as possible in your body just to go with the gravity. It's like it will increase the sensation of touching the buttocks, the seat bones, and your chair or wherever you are sitting. So you make yourself quite heavy. You keep on anyway your sitting position, but there are things that don't need to be held, like your belly can relax, your shoulders can go with the gravity, your arms, your mandibular inferior, so you open your mouth a little. Before you get asleep, so can you start generating a force that goes against gravity? And you do that by pushing with your sit bones a little, and that generates a minimal movement. But imagine these arrows going up from the sit bones, back to the sacrum, up, 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 spine, all the way up. So when you breathe in, you can follow with imagination this arrow up and push. And when you breathe out, you can allow all the soft tissues and shoulders, arms, go with the gravity. So give yourself 2 or 3 breathings like this, where you make yourself aware of the 2 forces in this very moment in your body, up and down. And allow this arrow that goes up, go up through the spine, up through the scalp, the crown, and go further to the ceiling. It's like the crown wants to touch the ceiling as the seat bones touching the chair. And notice that these 2 forces are doing like creating a space. It's like a traction, creating space for you to breathe, to be, to move. So now when you found this sitting position, these 2 arrows, you focus a bit on the movement that the breathing is creating in your chest, if any. And especially focus on the left side. Imagine your lung, your left lung, expanding and getting empty and smaller when you exhale. Make yourself aware about this kind of inner massage. Oh, this is massaging your back, your ribs. You can massage up, up, up to the shoulders. And actually, it massages your heart, gives energy in every breathing. So now we are going to visit the heart. So when you think about your heart, just grasp what your mind offered you. Was that a picture of a heart, of an organ, a color, a feeling, a temperature? Can you feel the heart pumping? And the gratefulness of it working all the time, even when you sleep. So now we are going to do this visit. And when you visit your heart, so you will see that you start walking around and there are a lot of rooms there. One room, you see the sign there, is the professional room, your professional room. So you go into your professional room and look yourself around. What are the colors, the rugs, the furniture, the walls? What you have there? A lot of memories, a lot of visions. People. So you look yourself around and then you see that there, in that special place, you have this screen with this coffer, with the most sacred of you. So you go to that coffer and open it, and there you have actually the essence, the core, the most important of you as a professional. What is in there? What's most important for you as a professional? What are you passionate for, about? And how do you do it? Can you start seeing yourself enacting this most important value? How do you talk when you are in contact with this? How do you listen? What's your face expression? What's your posture and breathing? How do you breathe? How do you move? So now allow the whole body, each cell of your body, to get in touch with this most essential part of you. Embody it. What are the feelings? What are the actions? So we identify 1, 2, 3 different actions, behaviors, that if, let's say that I look at you doing them, I will know that, now are you in touch with your values when you are doing this? And now start moving. Keep your eyes closed. Start really listening to your body. Keep that feeling, but just try to find all the joints possible that can be moved, stretched, open, down, like this. You can turn, you can flex and stretch. And then get your hands. I never remember how that's called in English, but you do like this with your hands. You can take out your glasses if you have some, and you just strike your face upwards and stretch like cat or a baby is waking up. Oh, snap. And so you can take your paper and pen and just write down something like, I of course forgot to show the beautiful slides I did for this meditation that you see now afterwards with the beautiful spine. And so you take the paper and pen and write what you found. And also reflect upon if there were any difference, because sometimes we find exactly the same, if sometimes we find something new, but most of the time people say that it feels different, and try to grasp that, what happened during this when you got in touch again with what's important for you. So you have some seconds here as well. And you can start sharing, for instance, if it was any difference for you in getting in touch with your values, so what's important for you, your essence, before the exercise or during it. Was there any difference? So you share whatever you want now in the, it's very inspirational to read each other's ideas. It's okay to write, no, I didn't feel any difference, or yes, it was da da da. So please share with us here how this feels. You feel better where you are tense in your body. Yeah, you get aware of it. That's true. But I was thinking about if it was a difference between finding what's important for you before the exercise and what's important for you doing this embodied mindfulness. So found value of love. And then I'm curious about how you embody that. It was more painful during mindfulness. Can happen. I wonder how it is. A lot of people tell me that sometimes it's the painful comes from the loss of not doing it, or longing after being able to do something. Yeah. So were more feelings. Anything else? An important reminding of why I do therapy, something that is often difficult to be in touch with while doing it. That's true. So you felt that you got more center. It was deeper, for Leo, more intimate sense. I thought at the beginning that my values were more intellectually based, yeah, deeper understanding and expanding knowledge. But when I looked in the drawer in my office, in my mind, the strongest driving value was kindness, compassion, and safe space. Yeah, yeah, that's sometimes we have this intellectual answers like, what am I supposed to answer, sort of more socially pliant, I will say. And then we found more other kind of, I will say, things, nuances in this exercise. Yeah, compassion as value. So this is independently of what you found now or not, because to do this like this, it's not easy either for some of you. That's depending on your experience of practicing mindfulness, of course. I imagine myself learning forward, listening before I thought something else. Interesting. With mindfulness, I was connected to my heart, and then came to me that the essence is love, compassion. Yeah. So this is the content of what you found. What the context I want to bring is for you to feel this feeling sense, the difference, that how can we work through the body, especially when we think that with the intellectual we are getting stuck in different ways. As I said, you can get stuck because there is a lot of words, a person talking too much, the same of the same, or no words. So these are ways to work with the lot of exercises like this that we can use to reach. And working with this, what have we done now? We have been working with the middle pillar, right? And with the values pillar. And some of you even touched the acceptance pillar, because some said it was painful and stayed there. So you can target the different processes even through the body. Feeling once in one level with my clients, human to human. That's beautiful. So normally after this exercise, we do break rooms. I wonder, and I would like to see if you have thumbs up, I wonder if you would like to first go through some of the lecture, and then if we have more time in the end, we do the exercise. Is anyone for that or not? There is one up, I see there. What do you say? I need to see your thumbs. Exercise now, and there will be other one. Exercise now, or more knowledge. Share my research. Oh, I see some of them. That's great. And then I see just one hand like this. That was not clear, but okay. So I go ahead with this because, as I said, otherwise it goes sometimes, especially with Zoom. So how do we, I mean, right, ACT has been brilliant in identifying processes that explain why we change, how we change, what is needed for change. But how do we know who needs what? Because we know that you had homework to do, right? There was thinking about, there is someone need to be muted, I think, somewhere, yeah. You had this homework where I asked you to think about for clients with, let's say, the same diagnosis, whatever it is, a trauma from childhood or depression or pain in the same place, but that they actually handled in totally different ways. And thus, you need to do different things with them. I bet you have been in that situation, haven't you? I'm just trying to see here. I see you guys because I have now my telephone. I see all of you. Yes or no? Have you been there that the same diagnosis or the same picture is taken in totally different ways? So Steve Hayes likes to talk about Paul, where he said something like, okay, how do we know what treatment by whom, which profession, for instance, is most effective for this individual with that specific problem, under which set of circumstances, context, and how does it come about? So which kind of intervention, let's say, profession, and how do we do it? Instead of treatment, I will just put today which processes of this, if you're a psychologist, how do you know which of these 6 processes of the psychological flexibility you're going to use and why? How you combine them? Why this patient will need more of this and more of that, and sometimes you get nowhere with values, but with the other patients, we just like, no problems. So how to understand that? That was something that was quite puzzling me, because in rehab, interprofessional, in a specialty care, I've been working mostly of the time, we get referrals, and then we need to decide what patient ABC needs, and the decisions, well, the decisions have been, I remember I got a lot of European money for building the first ACT clinic in Western Sweden, and I hired very young colleagues, and I had different programs, and I was doing the assessment. And so I was saying, oh, well, okay, this patient will need to go to this more short and intensive rehab, while this one needs to go very softly and in the long rehab. And they were looking at me like, you know, small birds waiting for food with open mouth, like, why? They have the same diagnosis. They have the same problems. Well, and then I had to explain that, yeah, the why is because that's called evidence-based senior gut feeling. I could not really explain what I was doing, and that was really bothering me, because as a trainer, as a senior teaching juniors, I need to be able to explain in a way that this hidden knowledge is, you can see it and you can systematize, because I wanted them to do the same, exactly the same assessment I was doing, because that ensure the patient's safeness in our clinic. So it is not okay that if I am sitting in the team meeting, decision A will be done, but if another physio is sitting there, a decision B would be done for the same, let's say, case. So I start realizing that, well, we may have ACT, we may have some techniques that work, but we don't have assessment tools that are systematized. And at that point, that was for 15, 16 years ago, I was not even research about that. It's like if you would generate the best medicine ever, but you don't know who benefits of it. You don't have indications for the medicine. So this was the problem. So I realized that, okay, instead of researching and creating new programs, I really need to start looking at assessment. Assessment that inform my decision-making directly with no gut feeling. That was the idea. So this also did that the health services change radically, because you can do a totally different. I'm going to post, I think the next video I'm going to do is explaining this experiencing of change in the organization of these clinics I've been consulting, how more effective it has been with this assessment. I don't have time to share that here, but I call it active assessment. So how to apply these ACT processes, understanding them, so we can understand the patient's differential needs, but also the differential responsiveness, so that you can create different programs. The point is that I only treat people in groups. I don't treat any individually. I'm going to explain probably more after. The groups are different in size, and so depending on how they are, in which state they are, but they are still groups. So the questions were concrete. What therapeutic process to target? I need to know that in the first 5 minutes. We need to really target, and the patient need to understand that as well. So all these technique of this assessment I'm going to explain for you, and the following slides are actually those that I explain my patients in the first meeting. And then how to use each component. This is more for us, and knowing exactly for which client we need to do what. And then understanding the function of what we are doing, why I'm doing what I'm doing, what I am trying to reach with this, very precisely. So this is one of the studies that's quite old now, 5 years. One of the first when I could see that the patients were looking at their psychological flexibility. I could see 4 different groups: those with low psychological flexibility, those with high. There's nothing new on that. You are very used to that. You can see people that are ready, as we say in Swedish, they stand on their toes, because they're ready to make changes, while there are others that, and those that are ready to make changes will, their rhetoric will be like, help me to help me. While you have those with very low, their rhetoric will be, help me, just make me healthy, do it. So they don't see themselves in the picture. And then there are 2 in-between groups. I'm going to explain this better, but this was interesting because there were 3 prior researches in the same line, but they found only 3 groups, or at least they could not really understand the middle thing. And the middle thing is where most of the patients are actually. It's like in between, unclear. And I could differentiate these middle groups, and I'm going to explain more about that. And the next, the last article was where I could see very, very clear these 4 groups, and I could also have the freedom, after working several years on this article, to explain it in other terms. So that was the one I posted in my page, because I could explain in the discussion, I could use more physiotherapeutical words, which was not easy, because publishing in a psychology journal makes it difficult for psychologists to understand this language. But I wanted to have a different wording. So how I did this, I started to use the data. In Sweden, we have a lot of databases with a lot of information, clinical information. The registry is a quality registry for pain. It has a lot of psychometric instruments, we can see here, let's see if I find my, here. This is EQ5D, quality of life, as well as we have somewhere there SF36, also quality of life, RAND actually. This was socio-demographic, the HATS, and they actually had the chronic pain acceptance questionnaire. And the questionnaire, I don't know if it is I forgot to look at that in Hebrew, but originally, the second version has been 20 items, and then there is it has been done in 8 items in English, and I validated that one in Swedish, and it's quite interesting, that one, and that they have this instrument among, there are many more instruments in this registry. There are 400 and some questions that the patients need to answer when they come to a rehabilitation clinic before they come. Then they need to answer after rehab, and then they need to answer 1 year follow-up. So if you don't have pain before coming to our clinic, you get pain after answering all these questions for sure. And I always thought that as a researcher, I love to have 400 variables, but as a clinician, this is worthless. So that was also my idea. So bear with me now. I'm going to show what I did. I used a statistical program that can handle a lot of variables and a lot of patients. Here, I think in this one, I had more than 1,000 patients. So I cleaned some variables, and we can see that the variables that are together or near each other, they are grasping more or less the same thing. And they are variables that patients scored high, and some patients. So quality of life, physical quality of life social. Here is activity engagement. They are doing household chores. They are doing outdoors work. They have a lot of quality of life, vitality, high health level. PW is pain willingness from the chronic pain acceptance questionnaire, which is an ACT instrument, and activity engagement is also part of that instrument of pain acceptance. So pain acceptance is both pain willingness and activity engagement. And in the other end, down there, I could find the opposite. Patients that scare, I'm going to show because we can see the patients here. You see the numbers, I also cleaned a lot. In here, I could see my patients. And I knew which patient scored what. So these green patients score high in this, and these blue patients score high in helplessness, high fear avoidance, fear to move, dysfunctional coping, high pain intensity or disrupting pain.
Gursiela?
Yes?
Gursiela, I'm sorry I'm interrupting you, but yes, we want to see your face if we can, and also there are 5 minutes to finish time, so I'm just gently reminding it, yes.
Oh, thank you.
It went quickly. Thank you.
That's cool. So I could see different groups, and I knew that group there was offered intensive, while this group down there was offered the slow, because they were in a different place. They were like more in a crisis. And then we had a group that was driven by anxiety. And then the last group that was a more, this is the group where most of the trauma, the patients with trauma were, that they were saying that everything was okay, but they were doing nothing. So these are the 2 variables. Also, I could see that there were a lot of variables that were about mental function, and in that axis in physical function. And I was mapping exactly how the chronic pain acceptance questionnaire is designed. I'm going to show. Because these 8 questions has also this activity engagement, that's the physical part in the Y, and the openness in the X. So I could see there these different typologies or profiles of behavior. So these people that are quite okay, and there we have very few. We have, this is pain clinic, but I could see, and these are people that are overdoers, and we have a lot of people also with trauma. I'm going to show their distribution with trauma. This is the group, the most difficult group, that where most of the trauma patients are, also some overdoings. So, and then we have people in crisis. So how is that mapping in, I'm going to show, let's see, in here, in the last article I'm writing now, that's how they distribute those that have pain and trauma. So now what I did is I took only those that have both pain and trauma. So the biggest group is this group with ambivalence and overwhelmed. And this is the group that needs a lot of, as you see, they score, if we go back to this, sort of, we can see this picture. Let's see if it's coming, it's a little slow now. If we see how it maps with the, wow, it's moving, here we go. So you can see how the statistic maps. So those that score high in both mental function and physical function, this is people that have had trauma and have pain, but they live a valued life still. And they can come with very specific questions to you. Here we have also a group that overdo because of anxiety. And then we have a group in crisis that experience still their trauma and their pain as a crisis, or they are in a real crisis, but normally it's their way of experiencing their flashbacks or pain. But this is definitely the most difficult group. And this is the group where we really need to work with based on the body. So let's see, I think that's where I finish. I can just show the last here is how do you then know what they need? And then I need just to see this here. So in this group, what we need to work with, what we need to work with is awareness. So that program with the group of people that are in survival mode, we focus only in awareness. And all the professionals work with mindfulness or awareness, or the OT will just go to the greens, the woods, and work with, finding different green colors with the patient, very basic things. And with this group, I see that. With the ambivalent that was down there, we work a lot with values and finding words. And with overdoing, what we need to work is openness, non-reacting exercises. And then with those that are in a good place, what we do is jungle, creating situations where they get very skilled in the three, and also being able to handle. So my last words, what I want to say is, this is not a personality kind of thing. This is different behaviors we have when we have problems. All of these 4 patterns of behavior, all of them are healthy. When we change job, or when we get the COVID, for instance, let's say, all of us, we got in crisis, and then we need to be very focused and have mindfulness and be present. And then we go from that state to the not knowing, where we need to not know a while and be open for this discomfort. And then we need to start doing things, and then we get more relaxed in this doing. And then we go all over back. What's pathological? Pathological is not to get stuck in a behavior, that you handle everything in a certain way. Let's say that you don't have a crisis. Your diagnosis is not killing you, but you still react as if it were deadly. Or that you overdo, and you never lay back. So pathological is to get stuck, to not have access to the executive mode. I also used to explain this with the nervous system. These up there are executive modes. If you grow up in traumas and crises and criminality or wherever, you will be stuck from back and forth in these behavioral patterns. So this is not personality traits. These are mapping behaviors that all of us need to handle very well. And if we have, that we can increase skills. For instance, I'm more a Wonder Woman kind of person. So I know that I need to be less reactive in situations that threaten me, and so on, and recharge batteries, and so this is part of how we work with this model. So, and this is how we could map. Well, so we work with more neuroplasticity, attach this with inflammation. You've seen in the video a little about inflammation and behavioral changes. So that was what I wanted to share with you, a little way of, I would say, structure and systematize understanding the processes better. And this is interesting because just answering 8 questions, we have been using that with medical doctors in the primary care. Just with 8 questions, you get an idea where the patients are, in which kind of profile they are stuck. And then we use the 3 pillars together with the patients in groups where they assess themselves. How much awareness do I have? How much engagement do I feel? How much opening? And then we work on that. We don't agree all the time, but it's a very good base to help them to discriminate and learn about their own processes. So we work a lot together with these tools. And then in the courses I offer, we learn a lot of exercises, how to do it in a very creative and body-based way. That's what I wanted to share. Let's see if I find, and then we do a lot of movements in my courses. We didn't do this today, but thank you for today. So
thank you, Gursiela, so much. Thank you very much for a very interesting lecture and also experiential work. I'm going to switch to Hebrew for a minute, okay?
Yes, of course.
תודה לכל מי שהגיע היום. אני מזכירה שמי שרוצה לתרום לגרסיאלה ולעבודה שלה, אז ליאור שם שוב את הלינק עכשיו לאתר שלה, איפה שאפשר לעשות את זה, וגם לפנות אליה אם יש למישהו שאלות נוספות. בגלל הזמן אנחנו רוצים ככה לנסות לסיים הכי קרוב לזמן שאנחנו יכולים, אז לא יהיה זמן לשאלות עכשיו, אבל אפשר להיכנס לאתר ושם לראות עוד חומר וגם לפנות אליה. I finished with the Hebrew, Gursiela. So if you want to say goodbye in any language you choose, you're welcome.
No, I can still use the English. Thank you so much for being here, and I hope to see you also in the future. We send the homepage. I'm doing a new homepage for the courses online, so you are so welcome. I hope to see you. Thank you.